So again, thank you very much for asking me to speak about this topic. And this is a topic of an initiative that we are trying to take where I live. And I live on the island of Ireland at the moment, a rather small place. In fact, I live in the northern part of the island. And it is a really small place of about 2 million people. And at the moment in Northern Ireland, we do not have any services for obesity whatsoever, okay? Bear in mind, when I'm going to be presenting this talk, I will be talking both about obesity on its own and obesity with diabetes. So we don't have any services at all. And one of the things which is good about that is that when you come and people ask you to develop services for obesity, you start from scratch. And therefore, you don't make the mistakes that have been made in the past. As we say, you should not make old mistakes, but you are welcome to make new mistakes. So we are going to learn we're going to learn probably what I have learned from the England, which is where I have done most of my work in order to try and improve services in Northern Ireland. Now, what I'm going to be presenting to you is not based. I'm not going to show you any fascinating science that Gertrude and the rest of us showed you already, which is very, very interesting. But hopefully what I'm going to talk to you about is how we can use some very basic concepts of a very complex disease to improve the care of our patients. The other thing that I would be very interested to do is to hear your thoughts, because what I'm presenting to you has not happened yet. We think that it will happen. And therefore, I'm looking forward to, first of all, your feedback as to whether you think this is a good idea, and also whether you think what I'm saying is applicable to you. Because I'm guessing that in Kuwait you have got similar, not exactly the same, but you have got similar challenges. And therefore, if you think that this is going to be useful to what you're doing with your patients with obesity and or diabetes, then that will be great, because this is how we develop evidence and we change policy. And again, what's also very important from our side is that we are, certainly where I come from, we really welcome collaboration with many countries, and we are always very welcome in the Middle East. I always enjoy my time when I come here or in other parts of the region. So we're very keen for collaborations, but the collaborations have to benefit both parties, not just one party, and that's always important. So let's put the laser on. Okay, so this is the way obesity care is delivered in England, and it has been the case for the last 10 years or so. England has got a population of about 55 million people, and what normally happens is we've got these tiers, as they are called, of obesity care. Tier 1, which is mostly public health, prevention of disease, give just some very basic messages in primary care in the community. Then we go to Tier 2, and Tier 2 is what primary care does. Primary care, general practitioners, the nurses, all in the community. And they give a lifestyle weight management program which lasts for 3 months. Okay? So that's the treatment for obesity in primary care at the moment in England, 3-month course. It's almost like having 3 months of antibiotics. So you have an infection, you get an antibiotic, the infection goes for 3 months. We treat obesity as an infection. 3-month course, and then it goes, it melts away. I'm being sarcastic here. Then we've got tier 3 services. So that means that people who have not responded to primary care, they have to all now go to the hospital to receive obesity care. Let me describe a little bit what that means. In the hospital care, and I think it will be possibly similar where you are, we have got a team of very good but very expensive people. So they've got me as an endocrinologist, I'm talking about when I was in England. They have got specialist dietitians, specialist surgeons, specialist psychologists. We've got a very good multidisciplinary team of very smart and very competent people. The problem is that there is only 10 of us, in each hospital. And we are trying to treat a disease that, at least based on body mass index, affects 25% of the population. Okay? So let me tell you another thing about these tier 3 services in England. They are only found in 50% of the counties of England. That means that there is no service for the other 50% of the counties in England. Again, I'm saying all of these things so that you can start thinking about what is available in Kuwait and in your regions. I appreciate it's a small place, but I'm sure that you'll have some similar challenges. So not only are we treating half the country, but we have got a very small team. And this team is unable, practically, physically, to see millions and millions of people that have got obesity. And even if you reduce the number of those people because you say they need to have a body mass index over 30 and a complication of obesity, then there are still a very, very large number of people. And finally, we have got these tier 4 services that are linked to the tier 3 services, and they involve surgeons. And we have got many, many good surgeons, but they only operate on less than 1% of the people that are eligible for bariatric surgery in the UK every year. So we have got a population of 55 million, and we do 7,000 operations per year, which is really, really bad, especially after what Gertrude has mentioned when it comes to the very impressive effects of surgery. So that's the system at the moment. And this is a slide that I borrow from Lee Kaplan, which nicely, this is a beautiful slide. And what it shows us is that the weight loss that we can achieve over the last few decades with our treatments, mostly pharmacotherapy here in blue. So you'll see that we've had some successes and many, many failures. And we have always been able to achieve about 5 to 10 maximum % weight loss over the decades. But what you'll see suddenly here in 2015, we now have got much more, as we have just discussed, effective treatments. They are not only effective, but they are also, at least up to now, very, very safe, okay? And again, I keep saying that I would be surprised if we find out that suddenly they have got some kind of a safety signal. So suddenly we have got effective treatments that are getting exponentially more effective when it comes to weight loss. So semaglutide causing 16% weight loss in people without diabetes. Again, always important to make the distinction there. And tirzepatide in people without diabetes causing 22% weight loss. Semaglutide in combination with cagrilintide causes probably 27%